Good evening, everyone, and a very warm welcome to this special session in observance of World Hypertension Day, organized by Voice of Healthcare, titled as Controlling Hypertension Together and Defeating the Silent Killer. So, hypertension continues to remain one of the biggest public health concerns globally as well as in India. So, what makes it especially dangerous is that it is often progressing silently without any obvious signs and symptoms until it leads to a serious complication like heart attack or stroke or any kidney disease as well. So today, with increasing urbanization, stressful lifestyle, some poor dietary habits, as well as reduced physical activities, hypertension is not longer restricted to older populations. We are also witnessing it in younger individuals as well. So through this panel discussion, we aim to explore that how hypertension is I would say representing from multiple perspectives clinical, nutritional, technological, as well as community driven and policy oriented. So, while discussing this, we'll move toward about the prevention, early detection, treatments, and equitable healthcare access to all. So, we are privileged to have an exceptional panel of experts and leaders who are contributing towards this issue, and it's my privilege to introduce all of them. Starting with, we have Dr. Rupesh Singhal, a senior consultant, interventional cardiologist at Shalvi Hospital, Ahmedabad. Welcome to the session, sir.
Yeah, thank you for having me. It's a privilege to be here.
And we have Dr. Manjari Chandra, senior consultant, nutritional medicine at Everhope Oncology and Max Healthcare. Welcome, ma'am.
Thank you, Dr. Muskan. Thank you very much.
Next, we have Mr. Manish Ranjan, who is a co-founder and chief executive officer of Nano Health. Welcome, Mr. Manish.
Thank you so much. It's great to be the part of the panel.
Next, we have is Ms. Aditi Khandelwal, co-founder and director of Heart Health Indian Foundation. Welcome, ma'am.
Good evening, Dr. Muskan. Thank you for having us.
And we have Dr. Kapil Mohan, chief executive officer at Artemis Cardiac Care. Welcome, sir.
Thank you, Dr. Muskan. Thank you so much.
So, starting with the session, we'll talk about the burden and the risk factors, as well as how important is early detection. So, begin with, we'll first understand that from Dr. Rupesh, that as an interventional cardiologist, sir, you must be managing acute or chronic cardiac cases. So, how often do you see hypertension is becoming the silent trigger behind heart attacks or complex cardiac emergencies?
So this is a very relevant question, and given the rampant nature of how widespread this disease is and how much it contributes to cardiac emergencies, it is very apt to call it the silent killer. So working in a busy cath lab, it's not very uncommon to see patients presenting with acute cardiac emergencies and heart failure to have underlying hypertension. What is more probably disheartening to see is a lot of time patients are not even aware about their disease, and if they are aware of the diagnosis, they have not been apprised enough to or about the importance of managing it properly, or it's just not being managed up to the quality of care that it's needed, and this sort of aggravates the cardiac conditions. So hypertension can cause a lot of shear stress in the blood vessels, which can lead to heart attacks. Sudden rise in blood pressure can lead to hemorrhagic bleeds like hemorrhagic strokes. It can end up with pulmonary edema, where because of sudden increase in blood pressure, your lungs get filled with water, and patients can have difficulty breathing. And these are fairly common cardiac emergencies with a common underlying reason of hypertension. And the sheer prevalence of unmanaged hypertension is huge. So almost I can say like 60 to 70% patients presenting with cardiac emergencies have some form of hypertension, and most of the time it is not being managed properly.
Thank you so much, Dr. Fish, for highlighting that how uncontrolled, I would say, blood pressure is quietly damaging the system as well as before any symptoms are also visible from now
Right.
or its body. Yes. So moving onwards and talking about another perspective, so I would like to come to Dr. Manjiri. That ma'am, from a nutrition and a preventive health perspective, what are the lifestyle changes or lifestyle, I would say, the perspectives that are linked with hypertension cases? And I think that is also increasing rapidly among the urban or youngster population.
Yeah, no, thank you, Dr. Muskan. Although hypertension, I mean, we know that there is an anatomical part to it, which is essentially atherosclerosis and, the coronary arteries getting lined by either calcium or cholesterol plaque built up. But the reason for all of this is also driven by lifestyle choices, nutritional choices. I mean, one of the reasons why, cardiac events happen and why there would be blockage of coronary arteries is the fact that there is inflammation, silent inflammation, latent chronic inflammation, most of which is driven by high levels of stress, poor lifestyles, sedentary lifestyles, and nutritional choices. Specifically for hypertension and increased blood pressure, we know that insulin resistance is one of the metabolic drivers of hypertension, like it is for any other metabolic condition like a non-alcoholic fatty liver or diabetes. And insulin resistance is directly linked to food and lifestyle choices. And therefore, the fact that we work long hours, the fact that we eat carbohydrate dense foods, the fact that we resort to eating out or ordering out many times, the fact that a lot of people depend on food outside because there's travel and office hours which extend beyond 7 and 8 in the evening. There's a lot of contribution of food choices to hypertension. And in fact, in clinical settings where we work with hypertension, this is also a modulator in a big way, that just changing the denominator of food, we're able to really help people reduce the numbers significantly. So besides, of course, the fact that people have genetic predisposition, there's high level of stress, food choices can play a very important part in both manifesting hypertension, also in managing and reducing the numbers in the long run. You're on mute, Dr. Muskan.
Yeah. So, Dr. Chandra, I was asking that nowadays, people are having modern lifestyle. So, talking about some youngsters or habits that we young people generally have is about moderation. That having smoking or alcohol in moderation is right for our health. So, is it true or is it just a myth that?
No, no, that's a complete myth. This is, I mean, sort of, trying to fool yourself. Any amount of smoking on alcohol is not safe for cardiac health, also for hypertension. And I'm sure everybody on the panel agrees to that. And, there is no way you can have, alcohol in moderation or smoke a little bit and think that it has no impact on overall cardiac. In fact, in terms of risks and the risk modulators for heart disease and hypertension, I think this is one of the biggest contributors, smoking and alcohol. So I don't think that there is no minimal or moderate amount of things that are safe considering smoking and alcohol.
Thank you so much, Dr. Manjari, for clearing that up and the points that you raised about nutrition and the lifestyle that we are following nowadays are also widespread concern for hypertension. So moving onwards and coming to Mr. Manish, that nano health, sir, it has worked extensively from chronic disease management. But my question to you is understanding that why does hypertension still remain a largely undiagnosed or undeserved condition despite of growing awareness?
So, most of us react to symptoms, and hypertension being largely asymptomatic, there are no symptoms, and because of which people have no reason to go ahead and basically get themselves checked. Right. So when I don't feel that there's anything wrong with me, I mean, why should I even go to go to hospital or even buy a device or get checked? So how does it get checked? Right. So it gets checked in a, let's say, occasional camp that happens at the organization or in the community. Right. Or let's say if I'm at the hospital, often not for, let's say, hypertension, right? Then it gets checked over there. And still, if it is not in a grave situation that Dr. Rupesh mentioned, then you will forget about it after some time, right? And basically that as a disease then keeps aggravating, and basically over a period of time, again, it is largely left untouched, and that's when basically it reaches a situation where we have to actually go to an emergency. So I divide the entire life cycle into three stages, what we call as a underdiagnosis, where people just don't, they're not aware that there is a problem, and we talked about that. Then there is even getting the right treatment. Basically, we have the best of the doctors available, but reaching them at the right time remains a challenge, right? And then even if once we reach them and we have a prescription in hand, we have bought the medication, still popping a pill for something which I don't even think I have a problem is still not the easiest thing to that. And that's what we call it poor compliance or poor adherence. So that, in large sense, basically leads to the situation that we are in. But that, thanks to everyone on the panel, I mean, hopefully we'll be able to reduce the hypertension by some extent through this effort.
Okay. Thank you so much, Dr. Mr. Manish, for highlighting the importance of awareness and as well as screening, which continues to be, one of the most biggest public health challenges nowadays. So coming to Miss Aditi now, ma'am, what are the biggest misconceptions that people, still carry around hypertension and preventive heart health also?
Yeah. Uh, so, Dr. Muskan, as Mr. Manish mentioned, and I would really like to extend the thoughts what he has said here, that I look fine, so probably I am fine, and that awareness to not have that and taking that thought, making hypertension as one of the most silent disease areas, I think that is the problem for now. And this is what keeps the right person, the right patient also to taking that pill. It stops the person from checking their blood pressures constantly and even showing up for next appointments. So honestly, knowledge is rarely the problem. It's majorly about how you are surrounded with those awareness sessions, if it's happening in the right direction, the right kind of audience is reached or not, is where I feel that that is the barrier. And let's see in a few months, years, and with the constant work that has been happening around the globe on this topic, may that ratio of 1:5 kind of ratio, we are able to defeat that soon.
Okay. Thank you so much, Ms. Aditi, for clearly also highlighting that how many people still present without symptoms, and that actually often delays the, I would say, timely intervention that they need to go for. So moving onwards in our conversation and coming to Dr. Kapil, that from a hospital leadership perspective, sir, how can institutions or cardiac institutions can contribute to effective screening instead of only tertiary interventions? So you're on mute.
Thank you, Dr. Muskan. I will start my talk just to apprise everyone here that why the prevention is so much required for the hypertension here. So just look at the data. Approximately 200 to 250 million of the population in India in India is approximately hypertensive adults, which we called about, and half of the population doesn't know that they are actually suffering with the hypertensions. Either they are remain untreated, they are discontinuing medicines, or they are into the uncontrolled way for the hypertensions. If we look at the western populations, population here in India is getting 5 to 10 years earlier than the western population. So it means that we are into the premature cardiovascular aging, which is the terms is going across the globe. And if we look at the World Economic Forum data, approximately $2.17 trillion is the economic loss from 2012 to 2030 in India just because of the cardiovascular diseases. 28 deaths 28% of the deaths are just because of the cardiovascular diseases, and approximately 20 millions of the productive years has been lost because of the cardiovascular diseases. So this is how the prevention is required. And I would say the nationwide cardiac care program will not be defined by that how many angioplasties we are performing. It will be defined that how many heart attacks has been prevented and we have stopped the patient to reaching to the cath lab. So I think on this way, I just want to inform and apprise everyone here. I thought of that how the preventions can be done at a tertiary level hospital, and then we thought of that there are the small thing which we can do. Hospital usually move from sick care. We have to move from the sick care to the risk management part. So care is only start in cardiology when the patient is reaching to the emergency. I think the care for the hypertension should start from the real opportunities in identifying the pre-hypertension states, the metabolic syndrome, the obesity and diabetes link, cardiac care program. Secondly, if we talk about the touch points in the hospital, only the cardiology OPD mostly are doing the BP screening, the blood pressure screening when the patient is reaching to the OPDs and everywhere. So we should emphasize that the blood pressure screenings are happening at every touching point within the hospital. Thirdly, we have to decentralize the prevention and the awareness up to the community level, then to the mobile screening, then to some IoT devices, to telecardiology, or some kind of the corporate partnership. Thirdly, if I would like to inform you that prevention is not just clinically important, it is economically critical because India is not ready to have the burden for stroke, the dialysis, the productivity loss or rising ICU admission. So, we have to take a pledge, and as an citizen, as a stakeholder into the healthcare industry, that we have to aware everyone about the hypertensions and their regular BP screening. Thank you so much.
Thank you so much, Dr. Kapil, for sharing those stats and with us, and that clearly highlights the burden of the disease and as well as those reforms that can be taken for hypertension, sir. So moving onwards and talking a bit about lifestyle, nutrition, and behavioral strategies that are there for hypertension. My next question is to Dr. Rupesh. Sir, patient often take a quick solution that they take a medicine and then it's over. So how do you convince your patients that lifestyle modification is equally important as medication?
Yeah, so this is particularly important and particularly challenging. In fact, sometimes it is even more difficult than putting in a stent and doing a thrombus aspiration. So what happens is, once you treat them, once you manage their acute conditions, most of the times, people will think that they are fixed, they are cured, and they can go back to their lives. They can go back to their burgers and stuff. And so it is an important job. I think it is very, very important. And uh, luckily, most of the doctors, I believe, are doing a good job nowadays about lifestyle education. So what happens is, uh, I mean, this analogy of uh, medicine versus lifestyle, as in binary needs to be broken. So if a patient, like whenever I am counseling my patient, the first thing that I will tell them that these are not two options of treatment that you have. They go hand in hand. They are partners. They are two legs of a stool. And if you don't have one, the other will collapse. So medicines, if you keep on taking your medicines and you keep up with an unhealthy lifestyle, eventually the medicines will fail. If you just stick to the lifestyle and not take the medicines again, it is likely that you'll end up in a health problem. So these are not two different arms of treatment, but these are partners and both need to be adhered to. Again, based on the education level of the patient, I'll try and drop some examples that the patients can relate to. So suppose if it's a young corporate employee, I tell them that lifestyle, interventions are probably the most highest return on investment SIP that you can do. So these are going to give you the best kind of results eventually, and don't look in terms of immediate gratification, that uh, if I walk, what is the benefit? I'm feeling fine, why should I walk? I'm healthy, like as it has been mentioned, because somehow lifestyle, a healthy lifestyle is more of a cultural aspect. And luckily, what we are seeing, the younger guys are doing better than the currently adult population. And hopefully, as mentioned by Aditi, as the this information reaches and the younger population keeps up, they will do a better job at it than we did.
Thank you so much, Dr. Page, for acknowledging the balance that is between medication as well as sustained lifestyle. And I believe that is also very crucial for long-term outcomes and the real-life scenarios that you just explained. So it was very nice. So moving onwards and coming to Dr. Manjari, ma'am, what are the most overlooked dietary and lifestyle triggers that are silently contributing to hypertension in India today?
Yeah, thank you, Dr. Muskan. Actually, most of the time people think that, as you were, one of the examples that you gave, which is a common thing across board, that people assume that it's okay to have a little bit of alcohol, it's okay to smoke once in a while, so that those sort of basic things are there in the overall population, that it's okay to take liberty once in a while, it's okay to not do the right thing all the time. But data suggests otherwise. Also, the thing about lifestyle and the denominators that we are talking about, whether we look at stress, whether we look at nutrition, whether we look at movement, activity, exercise, whether we look at even things as simple as your circadian cycle, all of these things actually make up the whole pie. And that pie is not something that you can do parts of. The whole picture will only become correct when you do each part of the puzzle. In this puzzle, food may be 60% of the story, but the other 40%, which is your sleep cycle, stress, and movement and activity, are equally important. Um, some of the common things that people tend to override or miss include very simple things like not understanding that that simple swap of homemade breakfast eggs and vegetables with a breakfast cereal that is convenient to open out of a packet, but the fact that these are completely two different foods and have a completely different impact on the human physiology. And also this common assumption that if I'm eating at home, it's mostly healthy food. Indians, even at home, sadly don't eat the right type of plate that they should be eating. Our food tends to be rich in refined flours and simple carbohydrates, something that's continuously driving metabolic syndrome and insulin resistance in a big way. The other problem is that once you are able to have a person even with some amount of metabolic syndrome, going back is not an easy thing. It requires continuous effort for a fixed period of time. We call it, when we talk to people and we try to explain them, that when you're doing nutritional lifestyle changes, it's almost like putting a cast on a broken hand. You don't do it for a week or two, you continue to do it for 12 weeks or 6 months, so that you're not just seeing changes in blood pressure and your weight and other parameters, you're actually able to address physiology, biochemistry, bioregulatory systems. And therefore the effort is big. It's always better to prevent and not get there instead of trying to address it overtly. Addressing takes more effort along with medication, and it's very difficult for people to comply with it while trying to live difficult long working hours and urban lifestyles. It's for us it's a continuous challenge to keep them on, motivate them, counsel them. One good thing, as Dr. Rupesh also mentioned, is that we see more movement in younger population. Either it is because of a lot of information being available and a lot of access to knowledge, that people are choosing to live better and understanding that living in India and living in a bit of pollution and longer working hours is already something that is putting them at a risk for lifestyle diseases. So now the effort that they try to put in from their end is slightly more than maybe a generation before. In fact, Dr. Muskan, a generation before us, maybe our parents, it was almost normal to accept that, people will get diabetes, people will get hypertension after a certain age and stage in life. It was almost accepted, but now people know that these are avoidable conditions, and they have to work towards being healthy. One of the other things to understand about health is that health is not it's not a setting that is there by default. You build your health by working towards it, and that's the message we need to continuously drive to people, that being healthy is not a default setting. You're not going to be healthy by doing nothing about it. Yeah, so it
Thank
takes, but it's worth it.
Thank you so much, Dr. Chandra, for jotting down all those relevant insights and considering how even stress and sleep are also becoming very important in our daily part of life. So, moving onwards and coming to Mr. Manish, sir, how can community-driven digital health programs can improve awareness, and how can they encourage regular blood pressure monitoring among the high-risk group?
So I think, like we had discussed before, if I don't think that I have a problem, right, I will not take a step to a right or to a left to basically do anything about it, right? So, I mean, the only way is how can we bring the care closer to them. So, one of the big ways in which I believe is wherever the people are, bring it to them. So, for example, the camps that we do. I mean, one is um, a good way is to do it in the organizations where people are working, right? So if just have one next to the cafeteria. So if they're coming and eating or going or taking a break, I mean that's a good place to just get it measured, right? Similarly, can we do in apartment complexes? Can we do it in other areas where basically it's where they are just walking, they're doing their course, and basically they just get it done. So one is to bring it very close to them. The second is that one-time events are not enough. So we have done I'm sure crores and crores of the camps by now. But when if you ask when is the next camp that's going to happen, no one would know about it, right? So can we make it more dependable? So let's say every Wednesday, we do something. Someone will be when the people know that someone will be there and I can get it checked. Then they'll wait for it, and that's what we have seen as like a one-time episodic care. Never works. I mean, or not doesn't work enough. But once we bring that continuity to it, then it has a very different and significant impact. The third part is that it's not only about like one time engagement we did and then just leave it. So especially once we identify that there is something is there, I mean we need to engage with them periodically. So one example I can tell you that we work in corporate, and we are doing a year-end analysis of everything that had happened, and we said that the HR was not there, and we got a call. Hey, I'm at a hospital. Some senior member is actually going through. So then we figured that hey, what happened? I mean, we all we stand here for that. So then we actually saw that in last 6 months, 8 messages were sent, and still that people didn't that person didn't even come for a checkup. And then we went back, and then basically the whole it was informed that if we this is why this is so important, the continuity of care is so important. So again, good cases that has happened, it's very important that they become the role model. They make it more continuous. Then basically that's where the digital media also plays a very very important role, because that if we can give them the tool to just go ahead and check and put the data periodically, then the continuity of care, whether am I doing better or not, right, plays a very very important role. And then can we flag it If I measure the BP and it's very high and it was 190 by something, then can we go ahead and tell that, hey, maybe you need to go ahead and see a doctor? And that's where I think a whole care can be made a lot more proactive, digital driven. Of course, this it can prioritize who needs more care than otherwise, and that we have seen made a huge impact in terms of people's health, in terms of community health, that we work with.
Thank you so much, Mr. Ranjan, for uh, highlighting about the community engagement, and I think the consistency that you clearly mentioned can help the bridge gap between the healthcare preventive and especially the treatment part that is also needed after you have been diagnosed with something. So moving onwards, Ms. Aditi, I would like to ask to you that patient communities they often know that should they do, but still they don't do it. So from your foundation's work that supporting survivors and their families, what behavioral barriers keep people from adopting healthy heart lifestyle even after some cardiac event, and how do these communities help?
So, Dr. Muskan, I think everybody on the panel would agree, and I myself have been playing the role of a caregiver for a very, very long time. The very first question, even as a wife of a heart attack survivor, I'd asked to the doctor that when will the medicines for my husband be stopped? This is one of the most common questions that we also get to hear in our community. And adhering to medicines, the fear of taking that pill, I have no idea why in India we do not support that. So that is one of the things that we have been highlighting in our community. And as also Dr. Rupesh mentioned, that it has to go hand in hand. There is no escape to it. There is a reason why behind the medicines it's written that you cannot stop these medicines by your own self analysis, and absolutely do not ask any of the AI tools, I would say. And why people are not taking it, because when you're surrounded by so many people who are questioning your choices day in day out, even for popping a pill, you will always feel that, okay, I have to stop this pill now. And that is the case wherein the repercussions start taking place. Yes, the stent is placed, yes, the surgery has happened, but if you're not taking those medicines properly, you're not getting your blood pressures timely checked, monitoring them, it is going to be a repeated case. Yeah. And the fear that, okay, these medicines are not good for me, oh my god, these are the life saving drugs, we cannot just stop them. So I think one of the most crucial part is here that when you hear from the doctor, yes, they can help you in cath labs. And I think one of the most important part that plays in keeping up with the pace is how communities are actually playing the role. So many of the experts have already talked about it. And I think when you have like-minded people surrounded by you, probably if my mom is not taking it, but her friend is taking that medicine, and if she says that I have not missed my medicine even a single time in last 5 years, that will make a change. This is what I feel.
Right.
Thank you so much, Ms. Aditi, for highlighting that. And I think you also mentioned about the emotional dimension that is associated with any disease management. Uh, so, moving onwards and coming to Dr. Kapil, we have been talking a lot about preventive health education, sir. So, how important is that within the healthcare ecosystem, and how can institutions encourage people to seek early intervention because before any of the complication arise for a patient?
Right, right. So, Dr. Muskan, as Miss Aditi already emphasized, I just would like to, supplement the thoughts that in our healthcare ecosystem currently, whatever we are doing, we educate the patient after the complication happen, rather than before the risk development. So, this is the problem. And everyone is talking about, Manish is also talking about that, everyone is knows about that, smoking, alcohol, diabetes, excess salt intake, non exercise, no physical activity, all these are harmful, but all this awareness is not converting completely into the action. So there is a reason, maybe the possible reason, which I just want to highlight, that we are getting to delays in telling the patients or the community that this is the risk. We are little delay in our education system in general. Secondly, we are talking too technical. Too technical means we are talking about the anatomy, we are talking about the arteries, we are talking about the veins, we are talking about the plaque. We are not talking about the simple thing that you may feel more sweating, more weakness in your body. Your kidney are silently going every day. Our all communications are driven by the emotions known as fear. So we only create the fear into the population just to listen you know and it is all communication are generalized. It is not personalized way, as Aditi mentioned, because of the support group. Her mother and the mother's friend are taking as a kind of a supporting each other. So they are this is more personalized. Whatever we are creating in awareness, it is moreover non-personalized. Secondly, I also thought about that what hospital can do. So I think we all of us must have been encountered into the discharge summary. And the moment you get the discharge summary, you rush to your home and doctor rush to their OPDs. Dr. Rupesh, no offenses, I'm just trying to telling the exact situation. So the moment discharge summary sign, the patient rush to the home and doctor rush to the OPD or to the operation theater. But what happened? Do we really make the population or the patient or their families understand what is written about in their discharge summary other than the medication orders? So I would like to emphasize that if we can add on few things like sleep education, like stress management, like physical activity plan, informing the family also about the whatever the disease, and including the basic scenario like physical activity, the BP monitoring, the sleep deprivation, as well as the nutritional counseling. Thanks to NABH, it is the part of discharge summary, but sleep, stress, physical activity plan, family counseling is still not the part of those discharge summary, where it should be included whomsoever is getting discharged from the hospital. So these are the small thing. Thirdly, we already talked about the younger population. They are more active than the populations, running into this phase. But there is a sleep deprivedness, which is the most important factor for, the potential heart diseases. They are onto the ultra processed food. They are digitally addicted. So these are the factors which we have to understand very intelligently, and it is a collaborative efforts which is required to make those population understanding that how the hypertension or the potential cardiac disease or the cardiovascular disease may affect them. So here, what is happening in India, the hypertension curve is directly proportional to the lifestyle inflation. It is not visibly now, but it is something is happening as a bubble, and some of the other day it definitely going to be burst. Now, when we talk about the prevention communication, it should be relatable, it should be more personalized, all the regional language or the people can understand, the corporate wellness engagement, the small physical activity corner before you get a food into your office mess or your school mess. I have not seen that any influencer is talking about hypertension or blood pressure screening. Otherwise, they are talking about the melodies, they are talking about each and everything. But I've not seen that this is happening. So ultimately, youth has to be more encouraged towards the health screening, so that all those initiatives can be the part as a part of the hospital stakeholder. We have to educate wherever we touch any patients whomsoever is coming or going from the hospital. Thank you.
Thank you so much, Dr. Kapil, for that descriptive response and those practical things that are really the highlighting the issue that we are facing nowadays. So, as we have talked about and touched on all the points about the burden, the prevalence of the disease as well. We'll talk about treatment and technology and the adherence that is there and that is required for the disease management. Coming to Dr. Rupesh, so you must have seen, from your clinical experience, what are the most common reasons that patient they discontinue or they modify their hypertensives, and how do you counsel them when they are also having comorbidities like diabetes or some cardiac issue.
Okay. So, paradoxically, the most very often what happens is why patients stop medications is because they feel fine. So this is because these are chronic diseases. They will get initially they are all very compliant. You after probably a heart attack, they will listen to you. They will follow you religiously. But over a period of time, there after the rehabilitation, they feel well. They go back to their lives, and then they sit. They think that they are feeling well. Why do I need so many medicines? पांच पांच छह छह गोली दिन का खाना कौन खाएगा? So what happens is कि चलो एक छोड़ के देखते हैं. Then that becomes an experiment. चलो दो छोड़ देते हैं. अभी भी कुछ नहीं हो रहा है. चलो बंद कर देते हैं थोड़े दिन के लिए. So this is how it progresses. They will always start कि एक छोड़ा, फिर दो छोड़ा. अभी भी कुछ नहीं हो रहा है. डॉक्टर साहब ऐसे ही दे रहे थे गोलियां, तब क्या करें? So this is that mentality what happens, and unfortunately, what happens is people lend back to us with complications, and then you have to, you see them in a soup, and you explain why did you stop medicines? Where were you? Why did not come for follow? So this is an education lag that needs to be tackled very importantly. So whenever my patients come, my go-to strategy for this is I will tell them कि भैया आपकी लड़ाई है, मेरा काम रास्ता दिखाना है. You are in charge. So if you tell them, what happens in India is कि डॉक्टर साहब तो भगवान है, डॉक्टर साहब की जिम्मेदारी है. You tell them मेरी जिम्मेदारी नहीं है, जिम्मेदारी आपकी है. You tell them that they are in charge. We are there in a supporting role. Once they are in charge, once they are empowered, you tell them the importance of this, and then probably the chances of sticking onto it is better. That is what I have seen in my clinical practice. What I see is I'll tell them कि मुझे बार बार मेरे यहाँ एडमिट होने का मन ना हो तो चालू रखना, वरना आपकी इच्छा है. Like depending upon the kind of patients, sometimes patients respond to humor, some of them will respond to fear. So I think the trick lies in listening to them. Once you listen to them, you give them ample time, you understand what their thought process is, and then you can improve the compliance. There are some very good combinations available which improve patient compliance. Pill burden is a real thing. Finance burden itself is a real thing, but pill burden is also a real thing. With so much comorbidities, elderly patients and diabetes भी है, blood pressure भी है, kidney भी खराब है. So most of these patients are on 8, 9, 10 drugs. So once you titrate the doses and you can achieve a stable regimen, it is, I think, very imperative that we cut short or combine them into a compliant, medically acceptable way so that you can reduce this pill burden. Again, finance is an important thing. We cannot just rub it off. It is a chronic disease. Most of these medicines are expensive. The government is doing a good job in promoting generics. I think if more quality control can be done with the generics, that can probably help. And also, we need to apprise when you're telling them about the finance aspect. When patients ask you, "Ki sir, बहुत महंगा है," you can always tell them. What I usually do is कि दवाई का खर्चा एडमिशन के खर्चे से तो कम है. So that is, you need to explain to them their own terms. So if you don't stick to it, imagine coming back to me with a second heart attack. That itself, the treatment is not going to be free, right? So you need to educate to them the importance of compliance. And also, you need to give them objective targets. So I have this habit of writing कि अभी आपका ये है, अगली बार आओ तब. So self-monitoring or home-based blood monitoring. So most of my patients, I encourage home-based blood pressure monitoring. Luckily, good quality devices are available at a very reasonable cost. So I'll ask them to maintain a notebook. And कि अगली बार notebook आओगे तो score card हम देखेंगे, तब ये number आपका average निकलना चाहिए. So you give them objective targets and they will try and work towards it. Also, once they target, you need to make sure that you educate them कि ये maintain करने में मेहनत लगेगी. Things can go wrong as rapidly as they improve. So this education is very important. With multiple diseases, what I do is I'll tell them कि पहले एक खतरा था, अब दो है तो मेहनत ज्यादा लगेगी. So, I mean, you have to educate them that probably also a statement that I make on very early on is that these are chronic diseases. I can help you control them. I cannot cure them. I mean, this is something that we need to educate because थॉट प्रोसेस इज कि मलेरिया का कोर्स तो खत्म हो गया, डॉक्टर साहब ने तो 1 महीने का दवाई दिया था, हमने तो कोर्स खत्म कर दिया, उसके बाद तो दिखाने जाना ही नहीं था. So this acceptance from the patient side and the medical fraternity side is also very important, that these are chronic diseases, these are going to stay for life, and so are their medicines. And we need to accept it that we can control them together, we can guide you, but ultimately it's your job to take the medicines, to make the necessary lifestyle changes. And without your efforts, my direction is meaningless.
Very well highlighted, Dr. Rupesh. And I think the points you mentioned about communication, medication adherence, as well as self-awareness about the compliance are these are the major key points that would definitely help for hypertension management, sir. Moving onwards, coming to Dr. Manjari, ma'am, how does a structured nutritional stewardship approach would apply in the context of long-term hypertension management, particularly for patients who are on multiple medications, as we were previously talking about, and where these dietary interactions with gut microbiome and metabolic balance, they all come into play.
Yeah, so it's actually then there's a lot of moving pieces in this whole puzzle. But as you said, you picked up the word gut microbiome. So the thing is that as everybody agrees here, and as Dr. Rupesh said, and Dr. Kapil said, that medications become compulsory, and they are, your doctors help them titrate them, and reduce the burden of the pill as much as possible, and try to manage patients on minimal medications. However, the medications also come with some attached basic side effects, one of them being the fact that they change the way the body is able to absorb certain nutrients, including micronutrients like minerals, zinc, magnesium, selenium, iodine. It also changes the way the gut microflora. So the fact that you have a gut microbiome which is thriving, there is commensal bacteria, those bacteria are doing multiple pathways in the body, are really responsible and are dependent on the gut microflora. Now all those changes are also happening parallelly, which means with the disease and with the lifestyle and also with the medications, we see the gut microflora changing, we see certain other things happening in the patient. So therefore it is also complex for the patient to manage everything together. And this whole thing of trying to understand, as Dr. Rupesh said, that the impact of not managing a chronic disease well and not doing the correct lifestyle nutritional intervention has a huge cost associated with it. The risk that comes with not doing this is very high, and if we are able to drive that information to the consumer, to the patient, that this may sound difficult to do, but not doing it is not an option, because then the impact or the risk is extremely high. That is something that people may tend to understand. Of course, I think parallelly, one of the things that we can also do is to support the patients with certain other things, because once they start taking the medications, they experience symptoms, which can be things like fatigue, changes in digestion, changes in appetite, etc. And that can be parallelly helped with introducing either, we work with some targeted probiotics, fermented foods, certain micronutrient supplements as and when required, so that those symptoms also are taken care of, so that the patient has a better, smoother ride while they're trying to manage the disease. So there are too many moving parts, and that's why actually the best strategy is prevention. And I'd also like to say one more thing, because we're discussing this on a forum which is public, is that when we talk of lifestyle and nutrition, it's very easy for me to prescribe or talk to a patient or explain. But for a person to implement it in their daily lives is in India is not so easy. We don't have walkable roads. We don't have cities that give people a chance to do exercise. We don't have clean food. If you are traveling, there is no access to nutritious food. There is nothing on an airport that you can eat which is nutritionally healthy. Most of that food is actually not meant to be eaten. It is some product sold as food to you. So the problem is that it's very easy to put down these recommendations and explain people, but at the policy level, I don't think we are doing enough as a country to drive this message through enabling it through the food that we make available, through the cities that we make, through the environment that we create that can allow people to live healthier lifestyles, so I mean, we keep saying that, eat your dinner at 7, but most people don't reach home by 9 or 10 p.m. Yes, so it becomes an impractical advice to give. And sadly, at no point a person can eat at 10 or 11 p.m. and expect to stay healthy for the rest of his life. He has to eat early in the day. That's how human physiology works. But because we have systems that don't enable health to be so easy, it becomes a task to keep choosing movement, better food, better sleep cycles. So yeah, it's a bit complex, and that is one of the reasons, Dr. Muskan, that in spite of so much of public information, so much of education, INC work, so many doctors trying to work. Now there is a whole bunch of lifestyle practitioners there who are helping people. Still, we see that non-communicable diseases, chronic conditions like hypertension, diabetes are on an exponential rise in our country.
Thank you so much, Dr. Chandra, for sharing that holistic approach. I would say that is much more required for long-term personal care or cardiovascular care as well. So moving onwards and talking a bit about digital tools or digital, I would say technology that we are having. So I would like to ask Mr. Manish that how can technology bridge the gap between the diagnosis, adherence, and the long-term follow-up, sir?
Thank you. So I think listening to all the doctor panelists, one thing I'm very confident now that whenever I fall sick, then and if I reach out to, if I reach them, if I'm able to reach them, then I'll be, absolutely good. But the main problem is what happens after I move out of it. So like Dr. Rupesh mentioned, I mean, no, he's scared, let's say me, to the health that, okay, if I don't take care of myself, then, of course, I'll fall sick. But the reality is, and that's what Dr. Manjari also said, there has to be a linkage or connection between, since I leave with the prescription at the doctor's chamber, and next time I have to go again, right? And that is the missing link. So I mean, I don't think the care or the diagnosis or the prescription is the problem. The problem is the continuity of care, right? And that's what where the digital basically health can play a very, very important role. And it can again be very simple, like Dr. Rupesh mentioned, write it in the book, right? But most of the times, where is the book, right? So I mean, these are some of the small things, if you are able to kind of inculcate into the habit of the people and make it easier and easier. Like one thing what we have seen is, if we can just give a personalized notification to the person every day on their phone for for a hypertensive or a diabetic, that hey, if you take lesser salt, it's good for your health, right? Hey, did you eat on time today, right? I mean, we keep seeing some cool notifications from Jepto, Zomatos, and all, but how many do we actually see about the health, right? But that makes a huge impact. If early in the morning, if I just someone reminds me, and because of that, I eat one kala jamun less, right? I think most of the times it will do the trick, right? And that's where the challenge of continuity has to be played by good digital. Another place where it helps is scalability. There can never ever be enough doctors, right? That's a very very precious set of people that we have in our community, right? But how can we extend that mission to more and more people who actually need care? And that's where again the role of health coaches, nurses, basically, and many other people in the health community, like what Saditi is doing. I mean, it's as important as well. And but all of that, basically, we try that. Can we make it personalized? Can we take it scale using our technology? Can we give not like, hey, please take care of health message to everyone, versus, hey, you have hypertension. I mean, did you measure your blood pressure today? Last 3 days, you didn't enter your blood pressure. Do you want to do it now? Right? And these are some of the small tricks which is basically added with a lot of empathy on the program. Of course, work together with the various people from various aspects, the clinician, nurses, public health specialists, and that has already proven to have a significant impact on the people. And I really believe that that's the only way to go if you want to make a measurable impact on the public health.
Thank you so much, Mr. Ranjan, for sharing the digital continuity, how it is really important to be managed at the scale of hypertension or our lifestyle as well, sir. So moving onwards to Miss Aditi, how can we make heart health conversations more relatable and actionable even for the younger population? And I think younger population often feel that hypertension is an old person disease. So would you like to throw some light on that?
Yeah. So, to younger population, to talk to them, the easiest part is talking their language. And as much as you can make it more relatable, it's the time of digital revolution which is going on. A thing can go viral even in 12 hours of time. So we definitely read about one person falling in the school premises, in the college premises, and then it just fades off like a news. It's not there. But to make that a revolution, we have to find again exact kind of audiences, the like-minded people to speak about it. Give them that forum that yes, this disease has caused certain kind of problems in their family. Many of them have lost their loved ones. Till the time we are not going to discuss it on open forum, people will not get the depth of this disease. The younger population, again, to reach to them, the biggest pathway is always the testings, the more and more awareness sessions that can happen, breaking down the medical jargons to the normal people in the normal code of conduct is something that should definitely come into the policy level dialogues as well. I was talking to one of my friends and he was mentioning that in his grandfather's time in India, there used to be a course called as Pak Vigyan, which is all about nutritional sciences was taught in the schools. And those kind of things, I think, is getting lost somewhere in our modern education system as well. So touch base the real youth, and you will see the change happening. And absolutely, this time the youth loves to show off if they are achieving a very small thing as well. They really focus on quality of life these days. It is not just about saving money. It is not just about saving a few assets for their future. They really want that quality of life to be there. As you already said, that they are comparing the Western world to what we are living here in the developing nation. And yes, the change is always going to happen for the good. So make those like-minded people come together, let them perform, give them those spaces, and you will slowly and steadily see the change. They will make a movement even in their families. I'm definitely sure. So talk to them in their own language, and we will see that change happening, and give them that forum as well.
Thank you so much for highlighting the meaningful conversations that are really needed for the support systems and to remain, I would say, consistent as well as to treat the disease that a person is going through. So, with that, I think we have talked a bit about prevention, the treatment adherence, the burden of the disease as well, and digital technology as well. So, my last question would be to Dr. Kapil. So, that what role do you see for telemedicine or I would say remote BP monitoring that is helping in sustaining follow-up care in tier 2 or tier 3 cities.
Right, right. So, Dr. Muskan, the challenges in managing the hypertensions or the regular BP monitoring is the two aspect. One is the early diagnosis or the early screening, and second aspect is the continuity for the care. So, I'll talk about the early diagnosis and the early screening, the telemedicines or the remote BP monitoring or the digital BP monitoring, IoT devices, or the technological enabled notifications. This will only create a capabilities for the early screening across the nation, and it is really make the all such aspect for the BP monitoring really accessible to the population at large. But the bigger challenge here is the continuity, which everyone has talked about, and the continuity can be mitigate can be achieved either by the two factors. One is the ease for the continuity, right, which is not there. There is no ease for the continuity, and secondly, there is no answer for the behavioral aspect of the patients and the family. Thirdly, I would like to emphasize one more thing. There is a barrier for the continuity also. One is the barrier that there is no reimbursement for the caregiver for the preventive health care, right? And there is no incentive, the moral incentive, the behavioral incentive, or the emotional incentive for the patient and the families for having the continuity of those aspect. So there are the several things which we need to tackle. Of course, the telemedicine, the teleradiology, the devices, the technological aspect will create the capabilities in nation, but it will not solve the problem because it is topped up by the behavioral changes of the populations, which has to be tackled differently. Secondly, as everyone has mentioned here, we are talking about the pills, but the pills is only start once you take the treatment. But whatever is happen, before how you are going to make the population aware about before the consequences happen, So let's talk about the post consequences, the post treatment factors. So pills is, of course, everyone will create a fear and the psychosis about the pills. So simultaneously, we also has to ensure that there is a little bit more emotional mental health counseling to the patient family, even it's a single pill. Secondly, we have to, if possible, we also have to ensure that is it any way that the pills can be avoided by the lifestyle or the nutrition or the food safety aspect or some of the other factors. So I think telemedicine and the radiology or the BP monitoring or the digital monitoring will not solve the problem at large. We also have to think about the food safety, as Dr. Manjari rightly mentioned. I have seen those ads. There is a ad of Fanta and the Lay's chips. The compositions, whatever is sold it out in USA is different. Whatever is sold it out in India is totally different. It is full of the palm oil and the sugar. And the same the composition, whatever has been sold it out in China is totally different. So I think then FSSI rule has to be very strict that whatever is in the market should only be available. And I think it also should have a tag. If you are below 13, you cannot buy this. If you are below 18, you cannot buy this. So there are the ways and means for restricting the population that they should not get it. Right. So this is all about from my side on the telemedicines and the continuity of the care.
Thank you so much, Dr. Kapil, and thank you so much for, I would say, segmenting and focusing that you shared with us for access, equity, awareness, and as well as the continuity that is required for hypertension management in India. And I think with that we'll conclude our today's session. It was a very insightful session, and for that I would like to thank all of you, your esteemed panelists and speakers, for sharing your valuable insights and practical perspective with us today. Thank you so much for joining.
Thank
Thank you
you.
so
Thank
much. Thank you for
Thank you so
having me.
much.
Thank you.